So my topic, without further ado, is on diagnosis of fetal anomalies, the Zimbabwean experience. Now, the outline of my talk, I'm going to begin a little bit with the background. Then I'll highlight the protocol we've been using at the fetal medicine units. Then I'll also talk about the Zimbabwean fetal medicine, the experience that we've had up to date. And then I'm going to highlight some successes that we've had, in particular one success that I'm going to highlight, and also a number of challenges that we've been facing, and then the lessons that we are currently learning. Now, the background of why we set up a fetal defects clinic was that fetal anomalies are structural. First of all, the definition is that fetal anomalies are structural and functional defects on one or more parts of the fetus that increase the risk of stillbirth. They may also cause a deficiency in the child's health, development, and quality of life. So what is this? That the major fetal anomalies are seen in 2 to 3% in fetuses, but account for as high as 20 to 30% of perinatal mortality. I think Prof. Chauke said on average there are about 8% in the developed world, and they range from about 2 to 18%. So we can see that this actually there's a high burden of disease of these fetal anomalies. But unfortunately, in our setup, in our country, we don't have any information concerning this. There have been studies that were done before. That is one study which I will highlight, which was more than 30 years ago by one of our specialists who also scans, Professor Minjanja, which shows that, yes, we have anomalies in our country, but then it did not highlight what the prevalence of these anomalies are. And also there was no dedicated fetal defects clinic then. So why did we need a dedicated fetal clinic, fetal defects clinic? Firstly, wanted to highlight the disease burden in our setup. And then the to be able to characterize and diagnose fetal defects to the highest level. Prof. Chauke mentioned that we have difficulties with people who say that they scan, but then they have no proper training. So this setting up a fetal defects clinic is supposed to deal with that, was supposed to deal with that. And then the other important thing about setting and to counsel them concerning the abnormalities that are discovered, their severity, treatment options if there are any, and also agree on a care pathway. And finally, the other reasons why a fetal defects clinic was very important to establish is that it should help us to create pathways for managing pregnancies complicated by fetal defects. Firstly, the obstetrician who's managing the patient does not know what's happening inside. And it's only through these specialized scans that they'll be able to tell what's happening. And then also, it also gives us an opportunity to liaise with the multidisciplinary team. When I talk of the multidisciplinary team, I'm talking about people who may become necessary in the management of the baby in the perinatal period. They can be alerted earlier. That is the pediatricians, pediatric surgeons, midwives. So if only in the setup of a fetal defects clinic could we achieve this. So that is one of those are the reasons that we felt compelled that we needed a specific fetal defects clinic. So 2 clinics were set up at 2 tertiary hospitals in Harare in 2019. These hospitals are namely Perinatal Group of Hospitals and Salim Mugabe Hospital. Initially, the Perinatal Group of Hospitals fetal medicine fetal defect clinic was up and running first, and it is housed within Buyane and Maternity Hospital. Now, these 2 fetal defects clinic, they have specific protocols which govern everything that we do in the fetal defects clinic. Firstly, the protocol concerns the induction of trainees who are coming into the unit. They're not just going to start scanning when they arrive, but they need to be inducted on what happens within the fetal medicine unit and how we scan. And then also it governs how we see patients. They have to be booked. They just don't come willy-nilly. And of note is that each scan is allocated 30 minutes, only 30 minutes, which enables us to deal with volumes. And then the scans which are done by trainees who have reached a certain level of proficiency. So you can't just do a fetal defects scan when you have not yet reached a certain proficiency. And these scans are done under supervision of our resident fetal medicine specialist, that is Dr. Verenga. And then of note is that the scanning is also done based on a protocol, which I'll highlight in a little while. And then once we've scanned the babies and we've realized that there are fetal abnormalities, these are discussed with the fetal medicine specialist. And then these defects are confirmed, a working diagnosis is made, and then the care pathway to be followed is then decided, obviously in consultation with the parents. And what normally happens is that if there is a fetal defect, but at that time the fetus is not compromised, then we aim to deliver a 38 weeks. Why this is so is because these babies already have problems. And then we don't want to add the problem of prematurity, unless only if the baby is then compromised and we need to do a preterm delivery, then we do that. In the event that a fetal defect has been discovered, which is lethal, again, in consultation with the parents, we decide on a management care pathway. Sometimes parents opt for conservative management, and at times they want a termination of pregnancy. So all these are facilitated via the Fetal Defects Clinic. And as I said, we scan according to protocol. We aim to scan in a systematic manner. That is, there are certain views of the fetus that we must obtain in order for us to be able to tell whether a fetus has a defect or not, and also which systems are involved. So as you can see, there are certain planes there that I've highlighted for the head. That is the transverse section, to be able to see some aspect of the head. Then also the sub-occipital pragmatic view. And then also we want to see the face, so the mid-sagittal view is good for that. And then also the transverse views for the orbits, lips, and palates. And then when we are viewing the spine, then it is the sagittal view that we want. And then we sweep across the heart to be able to see the 4-chamber view, outflow tracts, and then the 3-vessel view. And then also want to do a transverse and sagittal sections for the chest and abdomen. And also we must examine both the lower and the upper extremities. So as you can see, this is a highly vigorous protocol that we use to be able to detect these fetal defects. And then also, we also in the protocol is highlighted on patients who should be referred to the fetal defects clinic. This list is not really exhaustive, but what I want you to understand is that any baby who comes to the central hospitals who's been scanned elsewhere and is suspected to have a fetal defect must pass through our fetal defect clinic. And then any babies with abnormalities of fluid, that is either polyhydramnios or anhydramnios, because of the risk of fetal defects, must also pass through our units. And then any mothers who've had previous babies with major fetal defects also come for scanning in our units. And then mothers with also high-risk conditions, like mothers with diabetes mellitus who have been on insulin during the conception time. And then also mothers with rhesus who are rhesus D negative and have been iso-immunized. And mothers with lupus, if they have the anti-Ro and anti-La antibodies, must pass through our units. As I said, this list is not exhaustive, but these are women that definitely we must see. So after the compelling reasons that we needed to have a fetal defects clinic and also setting up this protocol, we started scanning patients. So up to date, we've scanned over 5,292 women. Now, why I say over 5,292 women is because initially we're not keeping data. That's one. Then the second thing, which is actually a challenge, is that we lost data at one particular time when we tried to upgrade our system. And now with this cohort of women for whom we have data, these were, on average, the women were 33 years old, that is the median age, and they were also of low parity with a median parity of 2. What we noticed is that their body mass index, though, showed that they were overweight women with a body mass index of 29. But I would like to highlight that these women were booked at 22 weeks of gestation. So maybe this might not be true reflection of the body mass index, as most women would have gained a bit of weight. Normally in studies, the body mass index is calculated using the weight that is there before the pregnancy or very early on at the onset of the pregnancy. But our women, as I said, booked on average at around 22 weeks. And then lo and behold, these women, they came to our fetal defects clinic for the very first time, the first consult, at 35 weeks. That was the median gestational age when they first came. Now, this is obviously a problem when it comes to diagnosing fetal defects. The babies are too big. So sometimes we can't see some body parts very well, like the extremities, and also like in the head, the brain structures. Because of the too many shadows that are there, it's very difficult to characterize abnormalities. But then this cohort of women, on average, they all came to us at around 35 weeks of gestation. But then these women were low-risk women in that most of them did not take part in substance abuse, smoking, or alcohol, which was good for us and good for, in terms of fetal defects, they were low risk for that. But what another important thing that we noted was that only 15% of the women managed to have a scan in first trimester. Please note, as I go through these characteristics in the demographics, sometimes the denominator changes. As in T1 scan, we're saying that only 3,399 responded to this question. So that's why we have a different denominator compared to the denominator of the cohort. So as I said, only 15% of the women managed to have a first trimester scan. And then only 36% of the women managed to have a second trimester scan. Now, we only asked were they having the first trimester or second trimester scan. It wasn't like in particular they had said the 11 to 13 weeks scan, or the T2 scan was done in the appropriate time, which is the 18 to 22 weeks. But then if they had earlier scan, it would help us in dating the pregnancy and also picking up abnormalities earlier. And then in terms of chronic illnesses, the women who came to us, most of them did not have lots of chronic illnesses. Only 3% had hypertension, chronic hypertensive. Women, only 0.3% had epilepsy, and only 1.7% had diabetes predating the pregnancy. What I want to highlight from this slide is the number of women who had a torch screen. Now, we do not routinely do a torch screen at the fetal defects clinic, but then there are some babies with defects that warrant that a torch screen be done. Out of these women, 194 women, only 3, which is 1.5%, managed to have a torch screen, which is again difficult in the fetal defects clinic setup. In that sometimes you see babies with polyhydramnios or fetal ascites, or with calcifications in the gastrointestinal system, which would suggest that they may have an infection, a congenital infection. And so you want to follow up with a choice screen to be able to say, do they really have an infection, and what to do with the anomaly if they have had an infection. But we could not do that for most women, as only 1.5% managed to do a choice screen. That is because it was being done in private, and most of them were saying that they could not afford to do this choice screen. Another thing to highlight is that only 0.4% were actually offered an unemployed screen. And now this is very important. It's because these women actually presented in first trimester, and so they had the opportunity to be offered an unemployed screen, whereas most women presented much later than the time where we normally offer an unemployed screen. And then also, only 9% of women took folic acid in the first trimester. This is a very cost-efficient way of trying to avoid neural tube defects, but our women, only 9% of them got folic acid in the first trimester. And then when we look at the trimester that we scanned these women, all the women who came to us, now if you can see that, you will note that the N has changed to 7,000 from the 5,000. It's because we are highlighting all the scans that we have up to date that we've done. So some women, because of the nature of their illnesses, of the nature of their babies, are defects, or maybe they're being followed up for preeclampsia, need to have more than one scan done. So because of that, the total number of scans that we did were much higher than the number of women who were scanned. But what I want to highlight is that 80% of our women, a huge 80%, were actually scanned in the third trimester. Again, as I highlighted before, this is not very good in terms of discovering fetal defects, not only in discovering them, but also in the management of these fetal defects, as these women come very late for scanning. In terms of the indications, why were these women being scanned? You find that over 50% of these women were being scanned for fetal well-being. Now, when you look at it, this was a central tertiary hospital. I would assume that because most of the women had actually not had a scan initially, that's why they were being sent for what they're saying fetal well-being. But I think we need to keep our data better so that we actually highlight if they had other complications besides just documenting that it was fetal well-being. These are some of the challenges that we need to try to address. Having said that, yeah, looking at the fetal defects data now, out of the 5,272 women, 142 babies were noted to have fetal defects. That made it 3% of the entire population that came for scanning. The number of defects, though, that were seen or that were diagnosed were 225. I must hasten to add that the number of women has not changed, or the number of fetuses has not changed with defects. It is because for every system or for every defect that we find, then we count it as one or as a different defect, because oftentimes babies have multiple defects. So because of that, that's why the number of defects is different from actually the number of fetuses who had defects. And from these 142 babies with defects, we only have outcome for 45 babies. This again is because of a lot of things. One of them that we lost data, and then also the way that we are collecting data, because we're doing it initially retrospectively, although we're trying to correct this. Now, the fetal defects that we identified by system in these 142 babies, as you note, the central nervous system defects were the highest, 21%, followed by the cardiac defects. This is actually comparable to literature, which notes that usually the central nervous system defects are the highest defects that are seen, followed by the cardiac defects. And then in this column here, I try to highlight which defects were more common in each system. Whereas with the central nervous system, ventriculomegaly was the most common defect that we could see. With the spine, it was the myelomeningocele. And then with things like the cardiac system, it was AVSDs, which were more common. So with each system, there were more common defects that we saw. And then perhaps to highlight the spectrum of defects that we could pick up, because we are in a fetal defects clinic, I'll zero in on the fetal defects from the central nervous system. This whole list shows the spectrum of the array of defects that we actually managed to diagnose within the fetal defects clinic, which is very important because previously, before we had fetal defects clinic, in the antenatal clinic, when patients would come, we'd see most women with diagnosis like ventriculomegaly, microcephaly, encephaly, but some diagnoses like aloe-holoprosencephaly were not seen. And what we've realized that sometimes women with scans showing defects were actually wrongly diagnosed. Whereas they'll say that if there's a severe ventriculomegaly, then in the end we're able to diagnose that it's not really severe ventriculomegaly, but it's a aloe-holoprosencephaly, which is actually a different prognosis. So this is one of the what has really helped in that by setting up the fetal defects clinic, we are better able to characterize abnormalities of fetuses. In this diagram, I'm just showing a choroid plexus cyst on this head of this fetus. Further to this, now when we look at the data, the outcome data of those 45 patients where I said we have outcomes from, what we see is that 36% of these fetuses were born alive. and 42% were stillborn, and 2% had early neonatal death. And we see that they came to us. First of all, I said when we look at the whole cohort, 80% had scans in the third trimester. This is also the same as in this special group where we had fetal anomalies. 55% of them actually presented in their third trimester. And then 18% it wasn't documented when they actually came to us. Again, this was late for trying to see fetal defects. And also delivery for most of them occurred in the third trimester. Obviously, after coming, most of them in the third trimester, delivery could only be done in the third trimester. Even for some who might have wanted to have earlier delivery, had they known about the defects earlier. In terms of the mode of delivery, most women, which is 62%, had vaginal deliveries, and half were spontaneous of the vaginal deliveries, that is, they went into labor, and half were induced. What is of note that I want to highlight, some of them actually had cesarean sections. 18% were elective cesarean sections, and 20% were emergencies. Now, others may ask, why were we doing cesarean sections in these babies who actually have abnormalities? The reasons for the cesarean sections, that is 38% of these women who had cesarean sections, 4 of them were maternal indications. That is, the mother had severe preeclampsia and needed delivery. And there were 2 of them had severe preeclampsia, and 2 had previous cesarean section. One had 3 previous cesarean sections, and the other one had 2 previous cesarean sections, and they went into labor. So because of that, they needed to have emergency cesarean section done, these 4 women. Then 8 of the babies, there were fetal indications for them, namely the defects that they had. They needed as a traumatic delivery as possible. And so some had sacroprocedural teratoma, vein of Galen, which are abnormalities of the blood vessels within the central nervous system, gastroschisis and anterior abdominal wall defect, AVSD, and then others. For example, this was a twin pregnancy. There was TTTS, and they needed preterm delivery, and others went into preterm labor. These quads, one of them had a fetal abnormality, so they went into preterm labor. So because of the monitoring that is difficult to do in our setup, it was said that they needed to have an emergency cesarean section for that. Then another one had an omphalocele. Unfortunately, for the remainder of the defects, these are 12 out of the 17, I was unable to tell why they had cesarean sections. So that means we need to obviously a better documentation of procedures that are done and the reasons that they are done. And then 22 of the women from the 45 had preterm delivery. That is 49% of them had preterm delivery. 23% of these 22 had entered into spontaneous labor, so preterm delivery, preterm labor, and they end up delivering with nothing to do with that. But if you note, 77% were iatrogenic. What does that mean? It means that because these men had come to the fetal defects clinic, had been discovered that their fetuses have defects, and they had said that they want to deliver early. They wanted termination of pregnancy. So in this case, we were able to intervene and offer them what they wanted. That is, they were able to exercise their right of choice. So this is something that the fetal defects clinic has definitely helped in. And obviously, the taste of the pudding, as they say, is in the eating. So the defects, what defects were actually confirmed postnatally? 53% of the babies with defects were actually confirmed to have these defects. 53%. And now maybe you ask me 53% and yet we've done some terminations. This is because these babies were born alive, some of them, and were able to do investigations, or they have obvious defects externally that we could see. So because of this, that we could actually diagnose that these babies had defects. And others, they were not confirmed. What does it mean? Most of them is because they were still born or they had early neonatal death. And by that time, those with early neonatal death were not diagnosed, they had not had investigations to find out whether they had abnormalities. For those who were stillborn and they had abnormalities of internal structures like heart conditions, we don't do post-mortem. So unfortunately, we could not confirm whether these babies actually had abnormalities or not. And then the rest, it was undocumented whether they had these defects were confirmed or not. And then now for the successes and challenges. Through the setup of a multidisciplinary team, which is always there and ready to discuss the management of challenging cases, we're able to do one intervention that I'm very proud of and which we hope will be the way to go with all other defects. This baby with a large umbilical who was noted in an ultrasound scan was discovered, discussed in the multidisciplinary team. And then it was said that the baby could have their anterior abdominal wall defect repaired at the time of delivery in theater. So what happened is that at the time of delivery, an elective cesarean section was scheduled, and then the pediatric surgeons were called, and the pediatricians were also called, and they came in, and at the time of the Caesar, whilst that cord was still attached to the baby, as soon as the baby was delivered, then the pediatric surgeons, they reduced the umbilical, and then they repaired it like that. So this is an intervention which definitely was only managed because the Fetal Defects clinic had been aware of this baby and had discussed with the multidisciplinary team. And also we've been able to do invasive procedures. There are a few of those procedures. Mainly, we've been able to do amniocentesis as a therapeutic procedure in patients. Unfortunately, we have not documented how many of these we've done. So again, we need to improve on our documentation of procedures. For the fetal defects, it's mainly patients with polyhydramnios who needed this intervention, who are threatening to go into preterm labor and still want to continue with the pregnancy. We've also been able to do feticides in patients who opt for termination of pregnancy. 2 feticides were done according to the data that we have of 45 patients. And then another success that we've had is that we've been able to roll out training of midwives and medical doctors from local clinics in basic obstetric sonography. Now, Professor Chauke highlighted that maybe we need to cascade down a sonography so that people are able to pick to see what is normal and what is abnormal, and then refer for further management when they see what is abnormal. So that's what we did last year, where we taught doctors and midwives from every province in Zimbabwe on how to do a basic obstetric sonography. We hope that is going to improve our pickup rates of fetal defects, as well as have more referrals from the provinces, and also that perhaps also it will enable women to present much earlier to the fetal defects clinic. Challenges have been many, and this list is not exhaustive, but what I want to highlight is that obviously that women are presenting late to come to us. It's a very big challenge. It has implications in the training of fellows. For example, first trimester scan, as we saw, very few people came in the first trimester or had first trimester scans. So obviously that means that the learning curve for first trimester scans is going to be very long for fellows who are in training. So we need to find ways somehow of bringing women to the fetal defect clinic, to the fetal medicine unit, so that they actually have their first trimester scan there, and fellows learn how to also characterize first trimester abnormalities. It has also implications in the care that we can offer our women. What do I mean by this? We are unable to offer aneuploidy screen timeously in women because they're coming at 22 weeks, they're coming in the 3rd trimester. So if only they come within the 1st trimester, then we can be able to offer them aneuploidy screen, which has implications on how we interpret defects when we see them. Because there are some soft markers of abnormality, like choroid plexus cysts, that we may see. In conduction, we say aneuploidy screen, we may be able to say, oh, no, this is really nothing to worry about since your aneuploidy screen is negative. Or we may say that this is something that needs further investigation as soon as possible, because also your aneuploidy screen was positive. Also, it means that when we want to do termination of pregnancy, we are doing it at advanced gestation. Now, this is a contentious issue for most people. Not only the parents of the baby who want to terminate, but also even I've noticed that some obstetricians who have to manage the case and some midwives are not happy when they hear that we are going to terminate a pregnancy, which is advanced. So we hope that we'll do away with this situation. But having said that, we do offer feticide so that the baby, when it comes out, it will be stillborn and does not cry at the time of delivery. Another thing that I want to highlight that has been a problem for us in the fetal defects are the prohibitive costs of diagnostic tests. I mentioned the Torchy screen that most women could not do. But then when we see women with anomalies, which are suggestive of some syndromes or some chromosomal abnormalities, we've talked to women about doing an amniocentesis and sending on the fluid for further diagnostic tests. But most women cannot afford these tests, and hence our hands are tied. We cannot really give them the proper diagnosis of what anomaly their baby is carrying, because we cannot do further tests. And then another thing that we have that is more in-house that we are having problems with is that we don't have in-house counselors who are dedicated to the fetal defects clinic. Now you have to understand that when we see women at times, women are distraught or parents are distraught once they learn that they're expecting a baby with fetal abnormalities. So after we've seen them in 30 minutes time, we counsel them. Then sometimes they need more time for counseling. 10 more minutes, some 1 hour, some 2 hours. People are different. So we think if we had a counselor specific for this clinic, they could do a great job with these parents, prospective parents, or these women who need further counseling. Also, that has been difficulty in following up parents of affected babies, especially after delivery. Some parents don't want to do anything to have anything to do with us because they discovered at the time that they came to us that their babies had defects. So it's difficult to get data afterwards. And it was actually very difficult because we're mainly managing initially patients retrospectively. That is the data we're collecting it retrospectively. And we've tried to change that because right now we're now following up, as I said, following up patients real time, whereby this has started at Harare Hospital, whereby we have a research midwife who every morning goes and finds out which patients have delivered. And among those patients, if there are any who pass through the fetal defects clinic, then she notes down the outcomes at delivery. But of course, it does not really take care of the problem of following up these babies afterwards. Once they leave the hospital, then again, maybe we might end up having difficulties following up. But at least the outcome at the time of delivery will be able to record it. And as I said, we lost a lot of data when we wanted to change the system for data keeping. So we learned that we need to back up data. And then also we need a longer follow-up of babies post-delivery to reflect true outcome. Most of our babies were followed up to 7 days post-delivery, and then a few were also followed up to 6 weeks, up to 4 weeks, post-delivery. So we need to follow up these babies longer for us to be able to get true outcome of the fetal defects and the pathology that they cause after delivery. Thank you.